It's always a pleasure to have a live transmission at India Live. Before going ahead, let me introduce my team. I do have Dr. Basant Kumar. He is additional professor in the department with us. And I do have Rahul and Arkit, who are the resident of mine. Seti is the technician in charge, and Nikhil is the technician who is looking after the imaging part. So may I request Dr. Basant to go ahead for the case presentation? Can I have the slide, please?
Thank you, sir. We have a very good case here. 45-year-old chronic smoker, normotensive and non-diabetic patient presented to us with angina of exertion class 2 from the last 6 months, and there is no family history of the coronary artery disease. Examination was unremarkable. He has a good renal function. EGFR is 99 ml per minute per 1.73 meter square. The cholesterol level is also fairly normal. The total cholesterol is 81, HDL is 28, and LDL is 32, and TG is also 142. ECG is within normal limit, and he is having the TMT positive at low effort. At 4 minutes, the TMT was strongly positive. Next slide, please. Yeah, we have a echocardiogram which is showing the normal LV functions. Next. So here we have the coronary angiogram. We can see the left system, the left coronary, left main distal is significantly diseased. The LCX ostium is diseased, and the LAD ostium is also diseased, and the mid and distal LAD is significantly diseased. RCA is not having the significant lesion. So we have a 45-year-old chronic smoker, male, with a stable angina, and the TMT is strongly positive. The plan is the left main bifurcation stenting. Here we have a true Medina 111 classification. Then the syntax score is 24, and we are going to do the left main with image guided PCI, sir.
Okay, so this is the case, a young fellow with the left main bifurcation disease, Medina 111. It's a simple bifurcation lesion. Whether to go ahead with the one stent or two stent, your opinion is most welcome. To the chairperson, please. Can I have the first angel, please?
Yeah, Dr. Varghese, Dr. Sandeep Singh here. So,
Hi.
so there is a significant disease in both the sides, especially the circumflex has a tighter disease as compared to the LAD infect over here. So, in my opinion, I think in this such scenario, you may have to go for a dedicated bifurcation. You may try for a coated balloon for the circumflex, but seeing the lesion which is tighter in the other vessel, I think that ultimately you may end up in a bifurcation disease or bifurcation stenting. So how are you planning to proceed?
Okay, okay. So what we have done by now, we have taken the transfemoral access, and it's a GL7F guide could cross the both the LAD and also the left circumflex lesion with the BMW wire. Next, please. And then here we have dilated both the lesion, left circumflex and also the LAD, left circumflex with a 3 millimeter NC and LAD with the 2.5. Next. And then there is a slippage of balloon at the time of inflation of both the balloons. Next. So it's basically a fibrotic. Calcium is not visible over here. So it's a mainly fibrotic lesion with the slippage of the balloon across both the LAD and also the left circumflex. Next. After having the balloon dilatation across both the branches, we had now OCT done. Can you run the OCT first run across the left circumflex? This is what we have a tight lesion across the left circumflex. How much is the minimum luminal area? 1 point. It's a 1.15 is the minimum luminal area across the left circumflex after having a dilatation with the 3 millimeter NC balloon. And the reference vessel at the distal left circumflex is 3.5, left main is 4.5. Next, Cine, please. Can you shift to the Cine? Can you shift to the Cine? So here we had OCT across the LAD as well. Can you run the LAD OCT? Okay, run it. So this is the run across the, this is LCX or LED? Okay, so this is the LED and this is the distal part. Can you demonstrate the ostium of the LED, please? So this is the ostium of the LED having the area of 3.24, but it's the focal lesion. And otherwise, so it's going to be, say, simple bifurcation lesion of the left main instead of the complex one, which do require the length of, say, more than 5 or 10 millimeter. Okay, next view, next scene. So then, after having the OCT across the left main bifurcation, both the LED, LCX, we had the OCT done across the distal LED, which seems to be insignificant disease. So can we have the run, another run of the LED for the distal one? Can you, yes, please. So this is the distal LED. Okay, run it. So this is the OCT run across the distal LED, which is having a significant disease with a minimal luminal area of, say, 1.54 millimeter square, which is quite significant. So angiographically, it seems to be that the disease is not significant in the mid LED, but then it's there in the OCT with the MLA of 1.5. So therefore, we decided to go ahead and I have no stenting of the mid LED as well. Next. 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 So it's a 2.5 millimeter balloon over here. Next. And it's a 38 millimeter stent across the mid LED. Next.
Yadav, you want to ask any question?
Yeah.
Just a minute.
Just hold on. Yes, please.
Dr. Vijay, this is Dr. Yadav, RD Yadav. So
hi, Dr. Yadav.
What technique you are going to do in the left main bifurcation? Distal is okay, LED, mid LED is okay. What
right.
Definitely you are going to do two stent technique. Among the two stent technique, whether you are going to do culotte, mini culotte, decay cross, or mini cross, what you are going to do, because the angle is less. Angle between the LED and circumflex is quite narrow.
Okay. So here, instead of, see, this is the simple bifurcation lesion instead of the complex one. The ostial LED is having a focal disease of, say, 2 or 3 millimeter, less than 5 millimeter. What's the length? And therefore, I am planning to go ahead for the provisional stenting, and if required, another stent across the LED after having the left main to LCX. So next view, please. So this is 3 millimeter, 3 millimeter. Yes, it's a 3 millimeter, 2.7538 across the mid LED. The stent is and dilated with the 3 millimeter. Next view, please. And this is after the mid LED stenting. What we are over here. Next view, please. So as there was problem with the NC balloon of 3 millimeter across the left circumflex, we decided to go ahead with the cutting balloon of 3 millimeter for a 3.5 millimeter LCX. Next view, please. So this is 3 millimeter cutting balloon. And this is what the result has been achieved till now. Any comment?
So,
I think modification of the plaque at the circumflex is a right strategy, because even on OCT also, the lesion was looking quite firm, and the way your balloon was not staying over there. I agree with you. It was a good strategy to use a cutting balloon over there. But I still feel that a dedicated bifurcation stent will be required in this case rather than provisional. I mean, that's my opinion.
Very nice. So next view. So what we have done, we have dilated LCS with a 3 millimeter cutting balloon and also the LED ostium with a 3 millimeter cutting balloon. Next. And then we had now OCT done across the left circumflex to look for how much is the improvement in the area after the cutting balloon and whether we do have an adequate cut across the proximal left circumflex and also the ostium. So can we have the OCT run, please? So these are the OCT run across the left circumflex. We are able to cut the fibrotic lesion across the proximal to the ostium of the LCX. These are the cut across the proximal left circumflex. Can you go to the left main, please? This is the Okay, so this is the next view, please. And then we went ahead with a 3.5, 33 millimeter stent from left main to left circumflex. Next. Next. So it's a iliocranial to have a precise deployment of the left main stent at the ostium. Next. 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 So it's 3.5 millimeter NC across the left circumflex. Next. 3.5. Next. As the left main is of 4.5, we dilated the left main port with the 4.5 12 NC balloon, and this is what the result is. Next. This is 4.5. Next. And this is the result after left main to LCX stenting. Next. And we do an ostium, which is quite okay. Next. And this is the rewiring of the LAD through the stent struts from left main to LCX. We were trying to have the distal struts across the left main to LCX to have wiring of the LAD. Next. So this is the jail wire been removed and another wire been there across from the left main stent to the LAD. And can we have the next OCT? Next OCT, bifurcation 3D reconstruction to look for. And here we have next view. Here we again had now, yes, the OCT across the LCS to demonstrate we have now well expanded stent across the left circumflex.
OCT is not seen. Yeah, now it's
OCT. So distal LCX, go ahead. Distal to the stent, there is no dissection. Proximally ostium. Can you demonstrate the ostial LCX area? How much is the area? 6.77 and left main. Okay, okay. And okay, fine. So now, can you demonstrate on 3D reconstruction where the wire is across the LAD? So this is the 3D reconstruction which has demonstrated the wire is from the proximal extract to the LAD instead of the distal one. In case the final kissing is required, one has to go from the distal extract. We tried second time. Next OCT. Next view, please. The last one, last OCT to demonstrate. So this is after 2 attempts, we were successful in crossing the distal struts of the left main to L6 stent to enter into the LAD. And here we are after this is the angiogram at present after crossing the wire across the LAD from the distal struts. And can you demonstrate the angiogram? So this is the result. Now, any comment about how to proceed further for the LAD? Is it okay, or do we need to go ahead for another stent across the LAD?
I think, in my opinion, leaving an ostial LAD with a balloon and cutting balloon injury may not be a very good idea since there was a significant lesion. So that way, I think stenting may be warranted. Like,
see, only concern is a simple bifurcation versus the complex one. We have modified the ostium of the LAD very well with a 3 millimeter NC followed by a cutting balloon. Flow is good. Let me see with after the kissing balloon dilatation, the OCT across the ostial LAD, how much area is there, whether there any dissection or not.
How much is the ostial? How much is the ostial LAD area now?
Not much injury.
See,
and
we have not done the OCT by now as we have crossed the wire just now across the LAD. Let me have the balloon dilatation across the LAD and then have the OCT examination.
before, just for discussion, before even looking at the
Do
OCT,
you plan?
if you haven't caused much injury to the ostium of the LAD, say, would any one of you want to just do a dab here? Because the Europeans do it with panache. And here the favorable angle is obviously the circumflex. So the primary stent into the circumflex is fine. But like Rama feels that if you have done a cutting across the ostium of an LAD, you got to end it up with a stent. So just for discussion now.
I don't think that is mandatory that you have done a cutting and
No, it's
you
not
have to put a stent. I mean, that is not the requirement. It's only what minimal diameter or area he gets after an OCT will have a fair idea, or if he's leaving any dissections over there, that point needs to be seen. Otherwise, there is a very good flow, Timmy, 3-flow in that. So angiographically, it looks disease
what
for
is
sure.
the ideal case to do a bifurcation left main with a deb in one of the branches and just a provisional stent in the other?
Generally,
What kind of a result in an LAD? Dr. Yadav, you two can participate. Rama, you can participate. Which you would leave. Go ahead.
Even in drug-eluting balloon trials, proximal LAD has not been included.
Negative.
Mid LAD, distal LAD, or RCA, mid RCA, distal RCA has been included.
So
Not in the proximal LAD. So proximal LAD is LAD, requires, which supplies 50% of the myocardium. So I will try to fix with the stent. Here, the option which is left for him is either he can do T-tap technique, or he can do a culotte here, modifying with the culotte technique, and then finish with the kiss. But
So-
plain balloon kissing and then drug-eluting balloon, I don't know how much it will be effective in the long term.
So my argument was that had it been without a lesion, for example, if it is not a 1-1-1 lesion, and you actually modified the lesion, and from earlier balloon angioplasty trials, we know that it's at
How
least
much is the size of
30-40%
the
restenosis rate if it comes to ostial
18 or
LAD lesions.
13
Like, so if it is not a lesion, then there is no point. There is no point in argument. Like there is a lesion, just significantly tight, even though it is a 5 millimeter extension into the ostial LAD.
normal.
But there is a
normal
lesion that was been modified.
normal.
So in your opinion, 1-1-1, there is no
Especially ostial LAD.
deb one of them and the stent the other.
Maybe circumflex, it's okay to take a deb chance and not in.
Favorable angle.
We're going to come back to him. Thank you very much, Dr. Rajesh. We are back here. Can you show us the
Yes.
LAD,
can we
LAD
go-
part?
Okay. So here we have dilated the LAD with the 2.5 millimeter balloon. Next. And this is what the result across the LAD after dilatation. Next. And it's a 3.5 across the LCX and 3 millimeter across the LAD. 3.5 is the size of the LAD proxima. So we have taken the 3.5 across the left circumflex and 3 millimeter NC balloon across the LAD. Next. Next. And this is the OCT. Can you show the OCT of the LAD? Just run it. And here is the LAD, which is having some minor dissection, not so significant to go ahead for. This is the point where there is a minor dissection following balloon dilatation with a 3 millimeter balloon. And just proximal to the stent, the mid LAD stent, the area is 2.35. It's somewhat on the lower side. Otherwise, also after having a balloon dilatation with a 3 millimeter balloon, we have a minimal luminal area in the proximal LAD. How much is the minimal luminal area? It's around. Go forward.
So what was the distal reference of LAD vessel size? 3.5.
It's a 3.5 at this point, and 3 millimeter, 2.75 distally, for which we have put the 2.75 followed by 3 millimeter balloon dilatation of mid to distal LAD stent. And here the reference size is 3.5. And therefore, with some minor dissection, some residual lesion just proximal to the mid LAD stent, we decided to go ahead with another stent across the ostial LAD. Next view, please. So we, after having a 3 millimeter balloon dilator, not able to cross the stent, and therefore dilated with 3.5 NC across left main to LAD, and this is the 3.5 18 millimeter stent being positioned across the ostial LAD. Next view, please. Next view, please.
Tap technique.
Next.
So
Next.
planning to do a tap.
That's right. Next. next view, next view. And here is this is 3.518 across the ostial LED as a tap technique. Next, it's a 3.5 balloon, stent balloon, and 3.5 NC balloon across the left main to LCX. Next, final kissing. Next. This is the result across the left main bifurcation, and now we are there with the OCT across the proximal LED to left main. Any comment?
Looks much better now. I mean, very comfortable to leave the lesion. I'm sure your OCT also will give you a very positive result now. I mean, that's what I think.
Here I have a comment. Here you see, the
Yadav has some comment.
angle is narrow between the LED and the circumflex, and by using tap, your must be 2-3 millimeter or 2 millimeter stent struts will be inside the left main, which is hanging without apposing properly, and at the carina also. So if I have to do like this, I will cross it and recross and kiss. If I have to do like that, otherwise I will do the culotte. Culotte is more robust and
this angulation was very favorable for culotte, you mean,
yes.
right? Yeah, that's what even. What do you think, Dr. Sandeep? What would you have done?
So
Tap or
instead
culotte?
I think the
do culotte.
Dr. Verghia, the comment over here from Dr. Yadav and from other panelists is that have you thought of culotte, and what was the reason to use tap instead of culotte?
Mom, I did not decide to go ahead with the culotte at this point of time because of axis of the metal jacket across the left main. And the culotte technique is going to be a concern, and therefore I prefer to go ahead with the tap technique. Regarding the extension, the stent struts across the left main from the ostial LED, we do have an adequate extension of the stent struts into the left main, as is evident in the OCT. Can you demonstrate how much is the stent struts of the LED extending into the left main?
These are this one.
And then we have nicely covered the ostium. So we have not left any part of the ostium uncovered with the LED stand.
How much is the ostial LED now in terms of area?
So how much is the area across the ostial LED? 7.21. Maybe I can go ahead and have a 3.5 NC balloon at this point across the LED and also the LCX, followed by the pot with 4.5. How much is the left main by now?
I think
So 4.5.
If you have done the tap and your stent struts is free inside the left main, it is better to cross with the circumflex balloon and then recross and then kiss.
Then
Dr.
the whole
Yadav,
chapter will open. Then you have to do it. It will lengthen the procedure significantly.
That's the thing. Your struts will not be.
But
free.
I think here
Long-term result will be
the result is looking very decent. It's only just an optimization is required. I think that's
right.
what is in your mind, Dr. Verghia.
Absolutely right. Can you demonstrate the OCTC with the distal crossing? We do have a nice ostial LCX, which is evident over here in the 3D reconstruction. Not much of the metal jacket across the bifurcation, other than some protrusion of the stent strut over there. And let me go ahead and have a dilatation with 3.5 NC across both the LED and the LCX. And then there is, as Yadav was telling about, there is no need to recross. We are already there in the lumen for both LED and LCX. It's only the balloon dilatation with the NC 3.5 across the bifurcation, followed by pot with the 4.5. That's what to be done. And maybe I can have an OCT imaging across the left main to LCX as well after having the kissing and the pot. 3.5 and 3.5. Any comment?
Well, we are going to close off the session because we are due for the next one. So thank you very much. I think the final result looks very good, but I'm sure you're going to go for OCT again, and maybe later you can tell us about the results. So thank you once again, and congratulations to the entire team. Let's give him a big hand.
Thank you very much.
Thank you.
Thanks.